I think the idea was that it might be useful to have a time for questions and answers, but I'm going to talk through a few bits here just on an introduction to PD, medication particularly, and then medication aspects that are good to know, and then the idea of motor complications, which are specific symptoms that happen in some patients which maybe need a change in medication. And then just a slide or two on drug development, and then really on to a question and answer. And for a couple of reasons, generally we would deal with questions that are general as opposed to very specific to one patient. So Parkinson's disease obviously is a very common problem. It's a common condition. The estimates of 12,000 in Ireland you often hear, they're really estimates based on similar Western countries. We don't have true data for lots of reasons, and things like how you count the cases and how carefully you look at what you categorize as Parkinson's disease all affect what number you would put on. But it's certainly a very prevalent disease, and 2 to 3% of everyone by late 80s or 90s would be the suggested prevalence. So it's common. It's been recognized for a long time. There are very old descriptions of symptoms and patients and people who probably had Parkinson's disease, but the formal coining of the phrase was from the 1800s, after there was a case series of a small number of cases by James Parkinson, and then Charcot, another neurologist, named the condition after him. So I've just listed here the cardinal features. So Parkinson's is all clinical. It's all a clinical diagnosis. And if you have the right symptoms and no other better explanation, the diagnosis can be made on that alone. So it's different to a lot of neurological conditions where very often several tests are needed to confirm a diagnosis. So the symptoms are listed here. Slowness of movement, stiffness in the muscles, and rest tremor are the three things that typically will be present when a diagnosis is made. And then the idea of balance can sometimes come in a bit later. So really we're talking about these three types of symptoms and no other better explanation. And in terms of what's happening in the brain in Parkinson's disease, we have a good understanding, and we have a good understanding of pathologically or at the cell level what's happening. And we understand what places are involved and what symptoms they cause. But what we don't have a good reason for yet is why the process starts. 90% plus of Parkinson's disease is what we call idiopathic. And that simply is a medical term to mean we don't know why it starts. It's a random event, not caused by anything specific that we can identify. And despite many, many studies over lots of years, no single specific cause is found for this condition in the vast majority of patients. In terms of making the diagnosis, I've just put a slide on DAT scan because this comes up. Technically, a DAT scan is just an X-ray study which looks at the amount of dopamine uptake, dopamine being one of the important chemicals for movement in a particular part of the brain. This test is not required to make a diagnosis, but we sometimes do the scan if there's any uncertainty about what's going on, or potentially other explanations, and we want to tease out what the exact reason for the symptoms are. But in an average presentation where things are making sense, it's not actually required to do this scan, but certainly it's well known that it exists. And the reason really is to confirm where things aren't very clear. In terms of treatment, I think it's always very important to remember for treating this condition that there are medication elements and non-medication elements, and they both have to be working well for a patient to be well. And then self-management, because this is a condition where you might see a clinic twice a year, being able to manage things yourself really is critical to how well a patient's doing. So this is just one of lots of graphics which just show the things that all patients need. So you need a specialist input, and you need a good GP who's able to keep on top of everything else. And then a lot of patients with Parkinson's disease need access to these second tiers. So physiotherapy, occupational therapy will be pretty universal, for example. And then there are a range of other things outside of that, which not every patient will need, but which it needs to be possible to access. So I suppose the point being that a lot of what you're seeing there is not medication. A lot of it is non-medication interventions by the right person. In terms of the medication specifically, though, there are some classic types of medication. So levodopa is the original, I suppose, and still the most efficacious or effective drug to replace the dopamine that's missing. And we typically put levodopa with carbidopa in a drug called Sinemet, which is an extremely commonly used drug. and that essentially directly replaces the missing dopamine. There are other types of drugs which try to achieve other functions. So dopamine agonists like Nupro or Requip, they don't replace dopamine, they mimic dopamine at the same place where dopamine should be. And then we have drugs here like Azilect or Comtest. They're drugs which, again, they're not dopamine, but they reduce the breakdown of dopamine when you either give it in a tablet or the intrinsic dopamine in the brain. So those first types of treatments really are all about adding in dopamine function where it's been reduced. And then we have other classes of drugs which are targeted at different things. So anticholinergic drugs, like, for example, Chemagen, can be quite effective for tremor, but a lot of patients will not tolerate it very well. And then we have drugs which encourage dopamine release, but aren't trying to directly replace dopamine, like amantadine. So these medications here, and there's a graphic just showing in broad terms where they're acting, are the core medications that essentially any patient on treatment will be on. And I suppose an important point is just what are the things to watch for with these tablets that are important? What are the particular things that can make them work better or less well? So in terms of getting the most from the medicines, a very important point is that levodopa or Cinemet or Madapar, those types of drugs, should be taken away from food, and that's particularly protein. So we suggest half an hour before or an hour after meals. And that can become difficult because, you know, if you're on 4 or 5 times in the day, it can be hard to pick out times that are separate from meals. But we try and design a regimen that is possible to stay as much away from food as possible. Sometimes you have to compromise when you're on multiple times a day. The other 2 points I'd make about the Cinemet, it's a multi-time a day drug. And so the recommendation is to try and be quite rigorous with the times. And what you find is that early on in the condition, that doesn't matter a huge amount. So patients aren't finding that if they're a half an hour early or an hour late, or even miss a dose, that they notice that much. But what can occur is over time, when you take the medication and it being nice and regular, can become more and more important for the drug doing a good job. So I always recommend it's a good habit to get into, even if it's not causing problems, to be moving around the times. I put NB hospitals there. Essentially, that's just to point out that if you're in hospital, it's extremely common. And we have 2 studies on this in James's, that medications don't get given at the times that they're supposed to be. So there's a change in the home schedule, and that can cause problems. So we've put a lot of work into trying to have time critical medication signs, etc., for patients who have these medications in hospital, because even moving the times around, even if they're then consistent subsequently, there'll be a shift in the control of the condition. And the last point I make about the food is that if you take it away from food, sometimes that causes a bit of queasiness or nausea. So it is okay to take a dry biscuit like a digestive or a rich tea with the Cinemet, so you're not on a fully empty stomach. That's really unlikely to affect the absorption. Medications like your Azilect and Selegiline, they're the MAOI inhibitors. The only point I'd raise there will be taking it in the morning, because in the evening time, it could sometimes have an effect on sleep consistency. So the generally is taken in the morning time. And then just general points, all medications, and sometimes patients on more than one, we recommend only changing one thing at a time, because it can be too difficult to tease out what's going on if you make 3 changes in a visit. And then the second thing is I always give a general advice around 2 weeks when you make a change to make a final call on whether you feel it's been helpful or not helpful or caused a problem. So don't decide day 1 and 2, decide after a block of 2 weeks, that change that I made, was it useful or not useful? And then I've just a point about alternative therapies and treatments, of which there are a huge variety. And the only 2 points I'd raise on that would be to try and source things from a reputable source, and then keep track of the costs, because the costs can become astronomical depending on what you're talking about. Just the last couple of points I'd raise would be just to be aware that symptoms in Parkinson's disease are extremely broad in nature, and that there are a large number of symptoms that do relate to Parkinson's disease that you wouldn't necessarily think relate to the condition, the so-called non-motor symptoms. And that's things like sleep, energy levels, bladder function sometimes, mood, lots of things that you wouldn't necessarily immediately think could be a consequence of the condition. It may be something that we can manage as part of the treatment of the Parkinson's disease. So it's always important at a clinic visit to list all your symptoms, even if it's not immediately clear is this related to the Parkinson's disease or not? And it is the case that any new problem you get over time may be part of the condition, including side effects from medication, or maybe not related to the condition at all. And it's important to make that decision. What do we think this new symptom is due to? And do we need to do separate tests for it, for example? And then I suppose the other one pointer I'd give coming into a clinic is have written down in advance, what are the things you've been noticing that you want to question? And sometimes, depending on your situation, having some form of log or a diary, even if it's just 3 or 4 days worth, because that's incredibly helpful when we're trying to decide what to change about the medications. What change should we make here to make better the thing that you're noticing? And then there's a couple of specific examples of side effects that are specific drug-related things. So 2 things I always counsel patients on for the dopamine agonists, so that's your Nupro, your Requip, and your Aripexin. The 2 things that are important to be aware of, they're rare, but because they're specific, we should know about them, are sudden onset sleep. So sleep disturbance and getting quite a sudden sleep attack is something that can be associated with dopamine agonists, particularly. And the second thing are so-called impulsive or compulsive disorders that can be caused by these drugs. And that's where you're shopping a lot online. Suddenly you're gambling in the betting shop a lot more than normal. So a change in that behavior, that can relate to the agonist. And it's important that you know that's something to watch for and let us know if it's happening. Levodopa, then the specific one is dyskinesia. And that's where you get some additional movements caused by the Cinemet. And we may have to adjust things depending on that. Rivastigmine, which is Exelon, a drug sometimes used for concentration memory, that can cause quite a significant drop in blood pressure on standing. So if you're noticing, so this is really just to highlight that anything new you've noticed may well be relevant to the condition or the drugs, and always bring it up at the clinic visit so we can tease it out. Motor complications then are these symptoms that start to creep in some patients later on. And there are things like dyskinesia, which we've just mentioned, where the medication starts to wear off towards the end of the dose. So you take a dose at 9, you do your next dose at 1, but by 12 o'clock, you've noticed a little bit of tremor coming in, so some wearing off. These kinds of motor complications, they are things which should prompt us to change up the medication, because they can be quite intrusive. They can have quite a big effect on your planning of your day. So again, a lot of the questions we ask in clinic and a lot of the diaries will look for these types of symptoms creeping in that mean we should be changing up the medication. And the last question I'm often asked is about some of the, I'll just skip over these 2 in the interest of time, the device-assisted therapies. So people ask about, what about deep brain stimulation? What about apomorphine duodopa? The main thing to say about those treatments is that the main reason to do them typically is because you're getting those motor complications, because there's a bit of dyskinesia, because there's some wearing off, and you can't fix that by moving the medication times around. So when we're talking about these device therapies, the main reason we're doing them is for these motor complications. So these are not things that are a problem very early on in the course of the condition, for example. And then the last 2 slides I have really are just around research and development. So I think it's always useful to have an idea of what's happening in the background when we talk about new drugs and when a new medication is going to be brought in for use in patients and by me in a clinic. So typically the process of coming up with a new drug, licensing it, and being able to write it on a prescription is quite long. And it goes from the preclinical phase, which is when you're thinking about what kind of cell effects, what protein patterns, or what changes are we seeing, really down at the basic science level that we could target. And you devise a drug or a molecule and you say, well, because this happens in Parkinson's disease, this drug may help. Going from that into medication treatments in patients, phase 1, 2, and 3, that process alone can take several years. The research studies, phase 1 is really safety, phase 2 is safety plus a little bit of, is there a signal here that we should be doing a huge randomized control trial? And then phase 3 is what you'll see reported in the news. A phase 3 study has reported an effect XYZ with a particular drug. And this is the point at which we start to get licenses for drugs. We start to talk about who's going to reimburse it. And so this is the point in the pipeline, which can be years or even more than 10 years from when the drug is first thought about to the point where we're talking about using it. And then after a drug is licensed, we get the follow-up data to show what's the real effect. Are there any other safety issues? So in general terms, research is looking at a couple of things in Parkinson's disease. A lot of research centers around optimizing delivery of treatment. So treatments we know work, how can we help them to work better? New drugs, which are for symptomatic relief, so tremor or concentration or whatever. New drugs, which are disease modifying. So this is the real focus now of a lot of research is, we know we have treatments that can fix the symptoms and control symptoms. What can we do to change what's happening at the cell level, the actual disease itself? So so-called disease modifying therapies. So a lot of current pipeline drugs are focused on this question. And then the other big areas in Parkinson's research are repurposing of existing drugs. So drugs that are already used in other conditions. Could they have an effect in PD? They're already licensed. We already have the safety data. Translation into PD is quite quick compared to starting from scratch. And then there's work going into diagnosis, assessment, and then non-medication therapy interventions, a lot of research in that areas. So these 6 areas here are where most research is currently happening. And the MDS, which is the big movement conference every year, there's usually an explosion of new data, and it'll be happening again in person this year. It'll be very exciting to see what's just coming off the pipeline in terms of for use in the very near future. And this is just to give a sense of what's currently happening in the area. So in terms of the trials that are currently happening, a lot of trials are in phase 1 safety and phase 2 expanded safety. So only a small percent of trials at any one time are in that phase 3. That's, next step prescribing. And the reason for that is you find in phase 1 and 2 that drugs aren't delivering what you might have expected. And some estimates would suggest that up to 90% of drugs you see in the lab as potentially being helpful start to fall out as you go along the pipeline. So only a small number get to the point of a phase 3 trial. In terms of what's currently actively being researched, a lot of it is small molecule trials. Some of it then is monoclonal. So you'd have seen the thing about Alzheimer's 2 years ago, the debate between EU and US as to whether it should be funded, and then some cell therapy. But a lot of it is small molecules. And you can see all the different mechanisms that are being targeted, the different things we know are happening in Parkinson's that we try and target. And will this affect disease progression? Will it affect the condition itself? So I suppose this is just to give you a flavor of what actually is happening research-wise at a global level. The focus is what can we get to phase 3? The focus is what elements of the disease process can we target in a meaningful way, and then getting the evidence that we're actually delivering an effect in patients. So that's really all I wanted to say, and I wanted to keep it short. Really, I suppose the summary is that Parkinson's is very common, it's very manageable. The treatments we have are generally effective, and a lot of the research is based on optimizing those. But the big thing we need is disease-modifying drugs, which can actually affect the condition itself. So with that, I'm going to stop sharing, because I think the thing then is just to maybe have a question and answer session. And I might hand you back to Mary just at this stage.
Thanks very much, Professor Bradley. That's great, and I'm looking forward to looking at those slides in more detail. There's a lot of information there, and it's good to get a synopsis of what's happening in the world of research and new developments. So I just want to open up the chat there and to know, does the digestion system slow down with Parkinson's?
Yeah, there's certainly lots of effects on the gut with Parkinson's disease, and they're direct neurological effects. So they're effects on the nerves that control how the gut moves. So the autonomic nervous system, so automatic functions like bladder, sweating, that kind of thing. There's a gut element to that. So the common things that everyone will be familiar with will be constipation is very common. And then secondly, you can get what's called delayed gastric emptying. So you'll take something in the stomach and it won't empty through as fast as it should. That can lead to a full feeling, it can lead to nausea. It can also lead to taking a medication and it not starting to have its effect the time you thought it would. So you take a Cinemet, and instead of starting to work half an hour later, it's working 90 minutes later. And that's a particular issue that can affect how easy it is to get good control with Cinemet. So for example, Duodopa was specifically designed to avoid this problem. The Cinemet in Duodopa is essentially the exact same chemically as the Cinemet you take as a tablet, but it's delivered in the jejunum, which is beyond the stomach. And it essentially avoids that issue where transit through the stomach can be variable. So it's an example of a development to optimize drug delivery. It's the same drug, but it's doing a better job because it's being delivered better.
Do PET scans reveal the progression of Parkinson's?
So PET scans really are just useful in all conditions where there's a change in the population of neurons over time. So classically, they're used in things like Alzheimer's disease to make a diagnosis and other types of dementia. There are signals on a PET scan that you can see, which are more specific to Parkinson's. And PET scanning can be very useful in differentiating typical or idiopathic Parkinson's from other versions of Parkinson's disease. You may be familiar with so-called atypical Parkinsonian syndromes. So they're conditions that aren't your classic typical Parkinson's, but have a huge overlap with the condition. PET can be quite useful in teasing those out. We don't tend to use PET in terms of progression Parkinson's wise. We tend to use patient and how the patient's doing symptom wise and scales like their EOPD.ie or the Montreal Cognitive Assessment, because in reality, if you're going to make a decision to add in a treatment for memory or to change up the treatment, you're going to base it on what the patient is presenting to you. You're not going to have a patient come in who says, actually, I feel fine the last 6 months, and then say to them, well, because of your scan, I'm going to change your treatment anyway. It always starts and finishes with the patient. So we tend to use patient factors, scales, examination to decide if things have changed enough to warrant a treatment change.
Right, thank you. Another question, I'm on 4 Solivo. I tend to skip the last one at 7. Is this okay?
Yeah, so depending on, so early in Parkinson's, you'll find this, that if you move the medication by an hour, if you miss one here and there, you don't notice that much. And you could make the argument, if you're able to miss it most days, if you don't really need it, I'll always recommend the lowest effective dose of treatment. So the first question will be, if that's 5 out of 7 days, I'd be wondering, should we just leave it out of the standard regimen and only add it back in when it's clear it's needed? Secondly, patients very much will often say early on in the condition that they don't mind missing a dose, it doesn't affect them because there's plenty of residual intrinsic dopamine function. It becomes more of an issue sometimes further along with the condition. And so as a kind of a general advice, I always suggest it's a good habit to begin, if you like, to be quite careful with the medication times, because it may become a time where it is quite important for being well on a particular day that your medication is fairly reliable.
Great, thanks, Professor. What's the most promising developments in regard to finding a cure for Parkinson's?
So I think the things that are most likely to come on stream first are the monoclonal approaches, which are aimed at protein folding or protein distribution. So things which prevent the process we know is happening from spreading to new neurons. So if you like, at the point where you can make a diagnosis of Parkinson's, very often 70%, for example, of dopaminergic neurons are affected by the time a patient presents with started with tremor. So already the condition has been present for a couple of years. And if we can identify through biomarkers, whether it's imaging or otherwise, that a patient has the very start of this, even 5 years before they might be expected to get symptoms, the first thing to say is that's the point to intervene on the condition. Second point is, I think the most likely things to become prescribable in the near future are going to be monoclonals, which affect, so they're infusions typically once a month or every 6 months, which affect how proteins are spread across the brain. If we can stop that process or slow it, then we stop new cell damage. And I think realistically, that's what's going to be prescribed. The controversy with the medication for Alzheimer's that was fast-tracked by the FDA was that it wasn't clear that, we were actually benefiting patients, that you were seeing that at 6 and 12 months, that it was having enough of an effect. So the argument is that where we should be putting the money, or should we get a drug that's better and fund that one? So there'll always be controversy in that way at the regulation level, if you like. But I think they're the most likely drugs to be prescribed in the near future, if you like.
Right. Should all Parkinson's have a gene review for the likes of LRK abnormality of detection? Yeah,
so in general terms, 90% plus of Parkinson's disease is not genetic in the way that you need to be concerned about children or anything like that. So we don't do these things as a routine. There are guidelines around who to do genetic screening in. So anyone with onset below 40, anyone with onset below 50 with a strong family history, they're the two main categories where we would tend to do a panel of genes. Over 50 onset, the likelihood of finding any of these things is incredibly low, so we don't do it as a routine. So we tend to go by those guidelines, and they're updated every so often when people have a steering committee to review them. So generally speaking, as almost all patients are over 50 when symptoms start, we don't do a standard genetic screen unless there's a very good reason to. For example, there's already a gene known in the family and there are 4 other people involved in the extended family who have the condition, and this may just be a very late presentation. But often then you won't find that gene in this patient if they're later onset. So that would be the current approach.
And what's the percentage of people that if they're carrying the gene of, say, their children getting it?
So if you're in the small percent of people where we do show a particular gene, then depending on which gene it is, it could be dominant, recessive, or X-linked, that you can work out what the potential risk family-wise is. But it depends on which gene it is, what the inheritance risk is. But the point is that 90% plus of patients aren't even potentially at risk of that, and we don't do the genetic screening for that reason. And that may adjust over time, depending on large-scale observational studies, but they're the currently recommended guidelines.
Are there plans for a national register for Parkinson's?
This has been talked about a lot. There's a working group at the National Neurology Program. This has been on the list for a long time. The issue that comes up, as it always comes up, is data protection. Where is the data housed? Who are the people who have control of the data? So that really has, and then COVID has messed up 2 years of that work. But it's on the list of things to do to have a registry. There are a lot of ethical considerations there in terms of, so the usual approach is an opt-in registry, where, for example, a patient says, I'm happy to opt into a register. So if XYZ trial is going to come to Ireland, I want to be considered for it. And that's the likely model, but it's not in place at the moment.
Grand, okay. Should Parkinson's be called a syndrome due to multiple progression?
So you're right. So there is this Parkinson's disease and Parkinsonism. So idiopathic Parkinson's disease is a specific disease which we understand very well and which is quite understood in terms of what are the interventions that we need to be doing at a certain time. So I would class idiopathic or typical Parkinson's disease as a disease. Parkinsonism or a Parkinsonian syndrome is the other 50 or so conditions which all cause the same types of symptoms. So you have Parkinsonism if you have the stiffness and the slowness and this tremor. Most of those patients have Parkinson's disease. Some of them have another Parkinsonian syndrome, and it's correct to call that a syndrome. So Parkinsonism is a syndrome. Parkinson's disease is a specific disease entity with, the implications for treatment pathways and for, regulatory and for things like the long-term illness is a listed entity, for example. I mean, there is an interest in SSRIs in terms of the condition. There's also an interest in it in terms of stroke. So it's proposed as a target, if you like, treatment-wise. The issue with SSRIs and what outcome you measure are obviously SSRIs are generally used for mood or anxiety. And we know if you improve mood and anxiety, you'll also improve motor function and sleep and fatigue indirectly. So it's always going to be difficult to tease out what's helping what. But at the end of the day, from a patient perspective, it doesn't matter once symptoms are better. So but in terms of getting regulation, getting license, getting funding, it is always going to be necessary to try to show why a particular agent is working.
Okay. Are there trials looking into the link between glucose intolerance, sensitivity, Parkinson's, diabetes treatments? Have you any comments on that?
Yeah, so there is obviously some potential overlap, and one of the drugs in use in the UK that's not particularly in use here for type 2 diabetes, there's some evidence for using it, and we've had trouble getting it reimbursed here where a patient doesn't have diabetes. So there is certainly interest, and this is the idea of repurposing drugs. So drugs that are already established in other conditions where there may be an overlap in some of the pathological mechanisms may help. But what we don't have yet is proof of why it might help or how much it'll help, and therefore who should be on this drug. And I think that is important, because if you start a medication and you have a rare side effect, you want to be able to say after the fact, well, the reason you were on that drug is because we had a reasonable expectation it would be useful for you. And therefore, we took the risk of the side effect and we were on it for a valid reason in the first place. And this again comes back to both the regulation piece and the reimbursement piece. So the National Pharmacoeconomics Group, which are based here in James's, who decide, for example, will duodopa be reimbursed? Which drugs will be reimbursed for which indication? They look at those factors. So it's not just, is the drug useful, but can we show it's actually helping a particular patient? Can we justify adding that treatment in if there were to be a side effect?
Since Cinematous has a 90-minute and a half life, why do we use slow release versions during the daytime?
Yeah, I mean, slow release, and I still see patients coming into me on slow release during the day. It's an old-fashioned approach to using Cinemat, and it just has become apparent over time that you get better response and effect on daytime function if you use short release Cinemat. I do have patients who swear by the fact they're on Cinemat CR 2 or 3 times a day, and if it's working for them, there isn't a reason to not do that. But typically, it's certainly younger patients where the needs are higher, where there's work and that you get more of a direct improvement in motor function with slow release or fast release, immediate release Cinemat. And then you may need to bolster that with, say, entacapone or something like that. But you're right. I mean, it was established practice, and I still see patients coming in maybe from older physicians who are on that kind of regimen.
The next question is, if the pill of study device to hit the gastric system at a certain point, why do some medical practitioners suggest fizzy water?
So, I mean, I don't routinely do that. I mean, there's some suggestion that you may get better activation of gastric throughput if you take some fizzy water, but I don't tend to do it as a routine. I think, if you have a significant issue with gastric emptying, then it's going to always be difficult to reliably say, if you're taking Cinemat, Stalevo, whatever it is, that you're going to have every day the same. And I think you're looking at whether a different delivery option is going to be more reliable for the patient.